is Brett of the Brookbush Institute, and in this video we're going over progressions of static self-administered release techniques. We're going to do dynamic self-administered release techniques, or pin and stretch techniques, for the adductor magnus, a muscle that has a propensity to get overactive in those with lumbopelvic hip complex dysfunction, specifically short and overactive in those individuals who have knees bow out, those individuals who have an asymmetrical weight shift. This muscle would be short on the side opposite the shift. This might also be related to things like a posterior pelvic tilt or sacroiliac joint dysfunction. I'm going to have my friend Brian come out. He's going to help me demonstrate this technique. Now, just like the static release technique, Brian's going to sit with his legs dangling. And we're going to use a ball. Softballs tend to work pretty good for the adductor magnus because we got to get around those hamstring muscles. The big difference here is once Brian finds the tender spot. Have you found the tender spot? We're going to assume that that's about the same site that we might have a little tissue adhesion. And of course, we want to free that tissue. We want our fascial layers moving well. So once he finds that adhesion, I'm going to go ahead and have him move just distal that adhesion. All right, so just slide so that the ball abuts the far end of that adhesion. You don't want to go all the way off it, but abuts. Now, I did have a little hard time coming up with this technique because I'm like, well, how do we make this dynamic? You can't abduct, you'll lose the ball. That'll just look weird if you just started going in and out with your thighs. We have to figure out some way of getting this tissue to move without losing the softball. We just have to remember the other joint actions that the adductors will do, right? The adductor magnus will do extension, so if Brian goes into hip flexion, he should notice that that's a little tender as it pulls the muscle fibers through that, what we'll assume is the adhesive point, and starts to free up that tissue. Now, things to watch out for is Brian does have to make sure that he is hinging at his hips, right? And he can use his arms to support himself, that's fine, and then come back, and he's just going to lean into it, hold for 2, and come back. And he's going to do that like 15 times. What ends up happening with your clients and patients that you really have to watch for is instead of hinging forward at the hips, you tell them to lean forward, and what do? They just kind of crunch, right? And if they crunch, that's spinal flexion, that's not hip flexion. They're not going to get any change in extensibility at their adductor magnus. Why don't we go ahead and turn sideways facing me so they can kind of see the difference between a hip hinge and just flexing over the ball. Good, so that's a nice hip hinge, right? And if he can get even further into hip flexion, he can, that's fine. Oh yeah. Right, and like I said, he can use his arms to help him, but he wants to keep his spine relatively straight. Show him the bad form again one more time. Stay away from this. This is what you'll inevitably see. All right, I'm doing it. I don't feel nothing. All right, I'm doing it. And you're like, no, that's not it. Oh yeah, you can see Brian's face when he's got it right. Good, and he's just gonna do like 15 repetitions, and then of course, we'd retest. Now, if you're doing this technique, I'm gonna assume that you've already been doing the static technique for a while. I wouldn't just take somebody and go, here, try dynamic release for the adductor magnus, because chances are they're not going to have good technique to begin with. They're not going to really know what they're supposed to be feeling. And I do want to get rid of any trigger points or tender points that are there first before I start working on this hypothesis of decreased fascial glide. Now, I should mention, getting a little bit more technical, if we needed to mess with the position of his thigh here in the transverse plane, right? Like if he wanted to go a little thigh out this way or thigh in this way to add more tissue extensibility before he went into flexion, he could. You guys can mess with those positions a little bit to get your client set up the way you need to. Obviously, if you were right at the end of a corrective intervention that included the adductor magnus and just needed that couple extra degrees, you might have to pull a little bit either in or out and then go really far into flexion to get that last bit of freeing of any fascial adhesion that we have.
In worked really well.
In worked really well for you? There you go. So make sure when you go inward though, you adjust your whole leg and set right? And that he's not using his adductor to hold him in, because then he can't get a release. Once again, guys, of course, I'd follow this up with reassessment. If my reassessment showed no change, don't just follow pain. I'm not just going to follow what Brian says and be like, oh, that's really tender. I want to see a change in his movement pattern. I want to see a change in his symptoms, in the complaints he came in with. And if this does have a positive effect, I'll keep doing it. And if it doesn't, then I just learned something. I narrowed down my intervention a little bit further, made it a little bit more specific. I hope you guys get great results from this progression. I hope you guys get great results from this technique. I look forward to hearing your thoughts about this technique. Please feel free to leave those comments. And if you have any questions, please feel free to leave them. I'll talk to you soon.